Hello and welcome to the 2019 National Resource Center for Patient Family-Centered Medical Home Education Series, Gaining Ground, the Primary Care Pediatrician's Role in Public Health Systems of Care for Children and Youth with Special Health Care Needs. My name is Kate Taft and I'll be the moderator today. I am the Associate Director of Child and Adolescent Health at the Association of Maternal and Child Health Programs. This is the first episode in a three-part educational podcast series brought to you by the National Resource Center for Patient Family-Centered Medical Home, or NRC, at the American Academy of Pediatrics, or AAP. The NRC is being joined by partners in the co-sponsorship of this educational series, including the Bright Futures National Center, Healthy Tomorrow's Partnership for Children program, AAP Council on Children with Disabilities, AAP Council on Community Pediatrics, the Association of Maternal and Child Health Programs, and Family Voices. To learn more about the NRC and co-sponsors, relevant websites have been linked in the bio for this podcast. The NRC is a cooperative agreement between the Maternal and Child Health Bureau of the Health Resources and Services Administration and the AAP. The goal of the National Resource Center is to improve the health and well-being of and strengthen the system of services for children and youth with special health care needs and their families by providing technical assistance and supporting implementation of the patient family-centered medical home model. By the end of this three-episode podcast series, participants will be able to do the following. Number one, describe the history and purpose of the Maternal and Child Health, or MCH, Services Block Grant, also known as Title V of the Social Security Act. Number two, discuss the role of primary care pediatricians in state Title V MCH Children and Youth with Special Health Care Needs Block Grant programs and partners. Number three, identify opportunities for partnership or collaboration between Title V MCH Children and Youth with Special Health Care Needs programs, families, and primary care pediatricians in advancing the medical home model of care for children and youth with special health care needs. And number four, describe the benefits of collaboration between Title V MCH Children and Youth with Special Health Care Needs programs, families, and pediatricians. The focus of this episode is on the history and function of the Title V MCH Block Grant. It will feature a conversation with Dr. Donna Peterson, Senior Associate Vice President at USS Health and Dean of the College of Public Health at the University of South Florida, and Dr. Ben Hoffman, pediatrician and the Director of the Oregon Center for Children and Youth with Special Health Care Needs, AAP member, and Professor of Pediatrics in the Division of General Pediatrics at Dornbecker Children's Hospital in Portland, Oregon. Towards the end of the episode, we will share a list of resources discussed during the conversations, as well as additional resources that can assist participants with medical home implementation. I would now like to begin the episode by asking our speakers to provide an overview of their involvement with state Title V MCH and Children and Youth with Special Health Care Needs programs. Dr. Peterson, would you like to begin?
Sure. Thanks, Kate. It's a pleasure to be a part of this. So I've been involved with Title V maternal and child health programs, it seems like, my whole life. I earned both my master's and doctoral degrees in maternal and child health from the Johns Hopkins School of Hygiene and Public Health. I was very privileged to serve as both a Children with Special Health Care Needs Director, Children and Youth with Special Health Care Needs, and as a Title V Director for a state health department for 5 years. And I am now in academia, as you said, but I've remained engaged teaching graduate students in maternal and child health, training and providing technical assistance to states, working with AMCHIP and the MCH Bureau over many years, and a lot of my writing has been in the maternal and child health area.
Thank you so much, Dr. Peterson, and very happy to have you here as well. Dr. Hoffman, would you like to introduce yourself?
Yeah, I come at this from a really different place. So I started out as a general pediatrician with the Indian Health Service on the Navajo Reservation, went from there to academics at the University of New Mexico, where I was involved in education as the residency program director for a number of years. And I've always had an orientation towards public health. I started doing a lot of injury prevention stuff, especially child passenger safety, and had used that to engage communities and eventually work at the policy level in a very different sort of vein than I'm doing now. I came to Oregon about 8 years ago, and an opportunity just fell from the sky to get engaged with the Oregon Center for Children and Youth with Special Health Needs even though I don't have a background in public health and I'm not specifically oriented towards kids with special health needs, I've been a primary care medical home provider for a number of kids with special health needs over the years. And this opportunity really gave me the chance to start thinking and operating outside of the four walls of my clinic, which was what was the most alluring thing to me in that.
Great. Thank you, Dr. Hoffman. And again, we're really pleased to have both of you here, and especially with the differing perspectives and backgrounds that you both have. So the history of the Title V MCH Services Block Grant dates back to 1935 with the passing of the Social Security Act, in which the U.S. federal government, through Title V of that act, pledged its support of state efforts to extend health and welfare services for mothers and children. So can both of you please share a little bit about the formation of the Title V Block Grant and how the program has transformed today? Dr. Peterson, would you like to begin?
I would love to, Kate. Thank you. This is something I've spent a lot of time learning about and really appreciating over the years, because I think our history provides us really important guidance and sort of guideposts for why we do the work we do. So what's really interesting to me about Title V is that the history of it goes back to the early 1900s. The progressive movement was kind of taking hold in this country, and the progressive movement believed that all of the new science and technology that was being created, coupled with activism, could really reform society. And there were a group of women reformers, ironically in some ways, working mostly in urban areas with immigrant populations, poor families. They were working in Chicago and in New York, and they were really being very, very innovative and very creative, coming up with new ways for community organizations to create systems within communities across all of the different areas that could support families. And really, they thought very, very long and hard about how do we improve lives for families. And so they were doing this really, really interesting work, but they were also dreaming big. They did not stop in their local communities. And they got together and they got President Taft to host the first White House Conference on Children in 1909. And the first one of its, I think it was the first conference of its kind actually anywhere in the world. And like any good conference, there were conference proceedings and a work plan that came out of the conference. And one of the objectives that came out of this conference, one of the goals, was to create a children's bureau. And by 1912, President Taft was signing into law the creation of the Children's Bureau in the United States. It was the first agency of its kind anywhere in the world. So it was the progressive era. We were behaving in very progressive ways, seeking to create those conditions that would allow children to grow and to thrive, because that was important for our growing society. What I love about the language of the Children's Bureau is how it's described. And it says that the charge of the Children's Bureau was, and I'm quoting, to investigate and report upon all matters pertaining to child life and welfare among all classes of our people. I'm going to read that again. To investigate and report upon all matters pertaining to child life and welfare among all classes of our people. And the reason that is very important, I think, to me and to all of the history that followed, all of the evolution of MCH Title V that followed, is that in those words you can see the seeds of what would become a sophisticated, comprehensive public health approach to ensuring the nation's future by attending to the needs of its children. It's about all children. It's about all the things that affect their lives, and it's about building the evidence base, investigating and reporting upon. So these women, again, coming out of the progressive movement, science coupled with activism could reform society, and that's what they did. So the history is really a rich and expansive one, and the women of the Children's Bureau, Julia Lathrop, who was the first director, Grace Abbott, who followed her, Catherine Lenroot, who followed her, and others in the early years of the Bureau, really decided to start by building that evidence base. So they conducted research studies on anything and everything that they could think of that related to children, and certainly things that reflected some of the conditions of the day. So they started with children in the workforce, the labor movement. They worked on nutritional studies. They looked at orphanages. They looked at the criminal justice system around youth. They looked at infant mortality. They looked at compulsory education. They really looked at anything that affected the health and well-being of children. And then as they did those research studies and created the evidence base, they used the science then to advocate for an appropriate response, for a public response. And they used their powers of persuasion, the authority granted to them by being in this agency, coupled with the science. And they said, having the National Children's Bureau is very important. It's a necessary part of our equation to create a better world for children, but it's not sufficient. And they said what we really need is to create a locus of accountability and responsibility within each state. So we would have national an overarching agenda, but it had to be realized within the states, within the conditions that existed within each state. And so they worked with members of Congress, and they found two people, a Mr. Shepard and a Mr. Towner, and they got them to pass the Shepard-Towner Act in 1921. And what's really interesting about this is that there's a lot of belief among historians that the only reason people actually voted for the Shepard-Towner Act was because in 1919 the women of the nation got the right to vote, and there was concern among Congress people that they would not gain the votes of women who were newly enfranchised if they voted against something that was for them. What's also interesting about the Shepard-Towner Act, and again, the women of the Children's Bureau were incredibly smart. What they created was the first program of grants in aid, which is a term of art, where the federal government gave money to states for a particular purpose, in this case, to create these maternal and child health programs. And so they really designed the federal-state partnership that we continue to enjoy today. Now, what's also interesting about this is that there was fierce opposition to this law from, among other groups, most prominently, the Catholic Church, the U.S. Public Health Service, and the AMA. And they each opposed it for their own reasons, but they worked relentlessly to get this law repealed. And in 1929, they succeeded. And because this is being sponsored by the American Academy of Pediatrics, I thought it was important to note that this is where the American Academy of Pediatrics began, because the pediatric wing of the AMA was so incensed at this that they pulled out and formed their own academy back in 1929. Now, 1929, we all know, not for this important milestone in MCH history, but rather because that's the year of the stock market crash and the beginning of the Great Depression. So now you have FDR in the White House trying to create his New Deal programs to get us out of the Great Depression, try to deal with the rampant unemployment, all of the things that were happening there, and there's all kind of history there that would be fun to talk about, but we don't have time today. But suffice it to say that for our purposes, he finally was able to work with Congress and create the Council on Economic Security, and this is a group that actually started drafting the language for the Social Security Act. Grace Abbott had left the Children's Bureau in 1934, but he appointed her to this council. Around this same time, the Children's Bureau had expanded its leadership ranks, and they were now including pediatricians, one of them being Martha May Elliott, who I'm sure that name is known to a lot of us. The American Public Health Association named its highest MCH award in honor of her. So she was now part of the mix. And Catherine Lenroot, who took over from Grace Abbott, was sent to the council as a sort of staffer. And so between Martha May Elliott, Grace Abbott, and Catherine, they worked to make sure there was language inserted in the Social Security Act to deal with the needs of the women and children of this country. And that's where Title V came from. So Title V is the fifth part of the Social Security Act. That's why it's called Title V. And they basically recreated what had been the program that they operated throughout the 20s, providing the means to get resources to the states to support the infrastructure that had been created. But when you look at the language, the very first sentence of Title V is so beautiful in its just directness and its simplicity. And what it says is, for the purpose of enabling each state to extend and improve, as far as practicable under the conditions of such state, services for promoting the health of mothers and children. So that's what it says. That was the purpose, and then the language goes on to, in effect, again, recreate the program they had created before. And that infrastructure then was supported again through Title V, through this program of grants and aid, through this notion of a federal-state partnership, and all of the things that have gone into the building of what we now know and love as Title V MCH, Children and Youth with Special Health Care Needs programs across the country. One last comment I will make is what I love about this is that it has been said that this is the longest lasting piece of law ever enacted in this country, that other laws were enacted before that and have been repealed or have been sunsetted over the years. Most of the original Social Security Act does not exist in any form like how it was created, but Title V does. It still exists with that same purpose to assure the health of all mothers and children in the United States. We, of course, expand that to include women and fathers and men and families and children and youth with special health care needs and children and youth without, but the fact remains that that core foundational principle that was laid down by those leaders of the Children's Bureau in 1912 endures in this country.
Thank you, Dr. Peterson. That was a wonderful recap of the history and reminder of the roots and progressive thinking and the importance of the need to focus on maternal and child health. And, it's an important reminder as you think about how those programs have expanded or evolved today. And so I'd like to turn to Dr. Hoffman if you'd like to share a little bit about some of the more recent transformations that can bring us up to what Title V programs look like currently.
Yeah, you bet, Kate. So decades ago, I think a lot of the Title V funds, especially those that went for children and youth with special health care needs, were funneled into programs that provided what we call direct services to kids. So you think about multidisciplinary, multi-specialty clinics to care for kids with really complex medical issues like spina bifida or cerebral palsy. There were centers that were housed primarily at academic institutions that may have had satellites around the state. I know in my own state of Oregon, there's an institution called the Child Development Rehabilitation Center, which started as that Title V funded multi-specialty, multidisciplinary program to provide care for kids with special health care needs across the state. As the healthcare system has transformed and we moved towards a fee-for-service model, there were resources for these clinics to support themselves through billing. And so there's been a movement in the last 20 years to move more upstream in terms of thinking about the public health approach to providing care for children and youth with special health care needs. And so there is a construct that is called the MCH, the Maternal Child Health Pyramid, which at the very top of the pyramid has those direct health care services. So, providing, again, funding for therapists, physicians, other care providers to do direct service for those children and youth. As we move down the pyramid, we increase the sort of complexity of the work, but we also increase the impact. And so as we move from direct healthcare services, if we want to think upstream and a little more broadly, we would move to what we call enabling services. And those might be things like supporting transportation for children who have mobility issues to be able to get to school, to recreation, to medical care, family support services, care coordination and case management, especially integration with Medicaid, supplemental nutrition programs such as those things for children and youth who might have metabolic disorders. And a lot of the public health programs, the Title V funded programs now for children and youth with special health needs across the country, sort of dabble a little bit in direct healthcare services, but have moved a lot more towards this idea of enabling, especially in the realm of care coordination. And I'll talk about that in my own context in a few minutes. Thinking more broadly and bigger, we get to population-based services, and those might be things like newborn screening programs, lead screening, immunization programs, sudden unexpected infant death mitigation programs, injury prevention, those sorts of things, where it's more systems level, and because it's more systems level, has smaller direct impact to any child or family, but a bigger impact across the community. And then at the bottom of the pyramid, the most robust and most important are infrastructure building services, and those include things like policy. So instead of putting together a care coordination program, being able to work with a state's Medicaid managed care organizations and ACOs to be able to engage them in directly in paying for some of those services at a policy level, which again is a much broader impact. So the pressure as we move towards what's been termed public health modernization is to move away from the direct healthcare services and even enabling services to really start working at the population level and at the infrastructure/policy level. I think many of us find that challenging because in trying to think bigger and broader, we can't ignore the fact that today there still are children and youth with special health needs across the country who have needs for direct services, and we can't just pull the plug on provision of those without ensuring that there's a safety net and those services will continue. And I think, especially in the context of the transformation of medical care from fee-for-service to population level, it becomes especially challenging. And I think there's going to be a really important role for pediatricians and other child health providers to work with the public health system to not just help innovate and develop, but to implement these concepts that allow us to move down the MCH pyramid towards population level and systems level stuff in a way that's going to keep everybody whole. Because, as a practicing general pediatrician, I can't stop providing care to those kids and families, today because they need my help today. But I also want to think bigger and broader downstream so that, in a year or 2 years, 3 years, we've got a system that supports those families and kids in a much more effective way. And it's really the difference between health and health care. And I think that to me has been one of the most instructive and disruptive parts of my evolution from a clinician to an educator to somebody in public health is the disconnect between healthcare and the way the system works for healthcare delivery and what's valued for providers and communities and the health of kids and communities, and they're often very much at odds.
Thank you so much, Dr. Hoffman, for that perspective on some of the way that the program has had to evolve in terms of the changing transformations within the healthcare system, and as well as our national policies and environments. And I think it reminds me one of the strengths and perhaps getting at what has maybe made this one of the most, or the longest lasting program or law is that there is flexibility built within the Title V MCH services block grant for states to broadly think about how they can ensure the health of MCH populations, including children with special health care needs, but also be responsive to their own states' environments, demographics, systems, and policies, as well as what's going on at the national level. So I think it's really helpful to hear from both of you on how the Title V MCH block grant was created and how it's evolved. And now we'd love to discuss, how it works at the state level, because you both have very diverse experience and expertise with Title V MCH and children and youth with special health care needs programs. So we'd love to hear a little bit about what your experience has been at the state level. So Dr. Hoffman, would you like to begin?
Yeah, so at a very practical level, so I think you brought up the fact, and this is I think a really wise approach to addressing public health issues in the same way that all politics is local, all health is local, and there are concepts and tenets, et cetera, that sort of bridge all communities, but the experience in rural Eastern Oregon is very different from the experience in urban Portland, Oregon. And the way that things happen in Oregon is very different than the way they happen in Iowa or Washington or Nebraska. And so having that ability at the state level to be able to think and act locally with the support of national structures is really valuable. One of the most important ways that we ensure that happens is that as part of Title V, each state is required every 5 years to perform a needs assessment of the community. And that happens at all levels of the Title V block grant, from maternal and child health specifically to adolescent health, to the component that's broken out for children and youth with special health care needs. And we're in the process of our needs assessment now. And in order to do that, we engage as broad a cross-section of the population across the state as we can, thinking about different needs of different communities, both geographically and in terms of economics, about race and ethnicity, around disparity in access, and around specific conditions and needs for children and their families. Based on the needs assessment, we are given options by the Federal Maternal Child Health Bureau to identify what are called national performance measures. So basically, based on our needs assessment, we need to identify a couple of target areas that we feel like our communities would benefit from most greatly. And there's some flexibility in terms of choosing different aspects of that, and we need to think about performance measures at the national level, and then we have some options for some performance measures at the state level. What we have done in Oregon for the last couple of needs assessments is focus on medical home as one of our primary performance measures and foci. The other national one that we're working on is the issue of transition from children and youth to adults, and it's everything from healthcare transitions in the primary care medical home to subspecialty care, issues of guardianship and independence and education and all that sort of stuff, which is a huge challenge. In the arena of medical home, there's a tremendous opportunity and a tremendous need for community-based pediatricians, especially primary care providers, as well as subspecialty care providers, to engage the public health system to improve both access and also the quality of medical home services. One of our current initiatives is building standing teams that exist in communities that cross different disciplines and sectors. So it would include a public health nurse who's based in a county, for example, one or more medical home providers, whether it's an actual physician, nurse practitioner, or a care coordinator, case manager from that medical home, and then other sectors that have a huge stake in children's health and well-being, from education to human services to child welfare to transportation systems to recreation systems and all that sort of stuff. And bringing together that team to engage in coordinated case management, care coordination for a family, with the belief that, and the evidence supports this, that you get people together at a table, they develop a relationship, they're able to problem solve and troubleshoot, both reactively and then eventually proactively. And as we're thinking about that MCH pyramid, the more robust and deeper these relationships become, and the more that these different sectors collaborate together to solve problems at an individual level, the more we can expect they're going to start to be able to affect things at a bigger system level, including and up to policy, to be able to impact things for kids. And so the way that we're building those teams is through using the ECHO model, which is basically a distance-based learning community approach that was developed at the University of New Mexico, building a learning community that convenes on a regular basis virtually through a web-based platform, to learn from each other about how they can build an effective team, how they can incentivize people to get to the table, and what they can do once they're together at the table. And in so doing, we're able to build not necessarily the individual medical home, but the concept of medical home and the idea more of a medical neighborhood, that the entire community now is coming together and cocooning around a child and a family to ensure that they have access to programs and services that they need.
Thank you, Dr. Hoffman. I'd like to turn it to Dr. Peterson if you'd like to kind of build upon that and share some of your own examples from your own experience with Title V involvement.
Yeah, sure. Thanks, Kate. And that was really terrific. I'm really excited to hear what you're doing out in Oregon. It made me smile to hear how wonderful this work continues to be. And it really reminded me of the strength of the partnership. And you talked about the state-local partnership, partnerships within community. The original sort of design of this was the partnership between the federal government and the state governments, and I think that theme has been part of what we've been doing since 1912. And I think the other aspect you mentioned is that it allows for a flexible response within each state, and then again down to the community level, because the needs aren't all the same, and that's another real strength of this program. And it allows for, and people have said this far more eloquently than I am about to, but 59 state and territories can engage in their own experiments and test their own hypotheses, and then we become a very large learning community across the country. And sometimes things don't fit because, as we've just said, the needs they're varied and they're diverse, and they really depend on the community and the people living there and the assets and strengths of those communities. But we can often learn a lot from these kinds of creative approaches, and I think that's one of the other beauties of this, is that it really is something that we share across the country. I think the other thing that you spoke to, that you didn't say this directly, but there's not a lot of funding in this program. I mean, it's this long-standing program. We've been doing it forever, but the funds are actually quite meager in comparison to what the overall need is. And so this idea of having to both at once meet the entire population's needs while also meeting the particular needs of certain parts of that population are a real challenge, but it really speaks to why it's so important for us to have strong partnerships. And I think you did a great job talking about that. And certainly in my experience, it was the pediatric community that was often sort of the first line of sight. They were the eyes and ears that told us what was going on, not only among their patients, but in the communities they served. And pediatricians as a group tend to be often extremely engaged, even outside of their clinics. They are advocates, as you said, and they become very, very important partners and help us see things like, it's not just what happens in the clinic environment, but what happens around it, and how do we build that system that supports families, and then how do we create a life course approach, which you also mentioned. It's not just how we take care of children when they're children, but how we take care of children as they become adolescents and as they become young adults and beyond. And those care transitions are often extremely challenging because the adult care system is not really equipped to deal with disorders that have their onset in childhood, as we know. So it means there's a lot of incredibly good work out there for maternal and child health, children with special health care needs, children and youth special health care needs programs to engage with. There's a lot of opportunity. There's a lot of things we could do. And again, I think the strength of this is that it is built on a science base. We are required to do these needs assessments and to continue to monitor the health of our population. In the off years, outside the needs assessment years, we have an opportunity to set priorities within the guidelines that have been established by the National MCH Bureau, but we can also tailor those to our local circumstances, which is what the framers wrote in the language in the beginning in 1912, and again when Title V was enacted as part of the Social Security Act. And I think there's just a lot of real hope and optimism out there for the future. It's a shame that this program has not become a model for how we address health and healthcare overall in the United States, because I think it's an incredibly practical way to approach the needs of a population. As was said, it's health and healthcare. It's not one or the other. We don't have to fight with each other. We need to find ways to come together, and that's what Title V enables us to do.
Thank you, Dr. Peterson. I think that was beautifully said, and I appreciate I think the brief journey we've had through the history of the Title V program, and getting into specifics of how it's evolved and works today. And I certainly would love to spend a lot more time and delve into many questions and follow up, but I know we have limited time. So just in closing, would like to ask both of you if you would share any tools or resources with our audience that you found helpful in learning about Title V, MCH, and Children and Youth with Special Healthcare Needs programs. And Dr. Peterson, would you like to go first?
Oh, sure. Sorry. Yeah, so I think there will be a resource list available attached to this podcast, and there are certainly lots of materials available from the Maternal and Child Health Bureau. At HRSA, one of my favorites is the MCH timeline, and the link to that will be available. AMCHIP, of course, has a wealth of resources to support Title V programs. The Maternal and Child Health Journal, if you are not reading that on a regular basis, I would encourage you to subscribe or to access it online. This is a journal we started in the 90s as a home for both the research and the practical applied work of maternal and child health. So it's a great resource for all of us. And then there are a couple of classic textbooks that are out there. The series by Helen Wallace, who ran the first MCH-funded training program in public health out in California, and then another series by Jonathan Koch, who was at the University of North Carolina, Chapel Hill, series of textbooks on maternal and child health that are also great resources.
Great, thank you. Dr. Hoffman, did you have any you'd like to share as well?
Yeah, I mean, I've had a very steep learning curve in terms of becoming familiar with issues around children and youth with special health care needs in the public health structure. I would encourage, especially for pediatricians, to get in touch with your state maternal child health folks. There will be a director for the overall maternal child health program, and then specifically a director for the programs for children and youth with special health needs. I can tell you that I always welcome that contact. I'm starving for that contact. I think that the Academy, and especially the National Resource Center for Patient Family-Centered Medical Home, is a phenomenal resource. And I would also really encourage pediatricians to reach out to family organizations, especially your state family-to-family program, because engaging with families who know their kids, who know their communities, is a really rich and powerful experience, and has provided me with a ton of both information, satisfaction, and opportunity to really work at the level that impacts what families really go through.
Thank you both so much. I think those are great tips on resources and starting places, and certainly, for the state program directories, I know at AMCHIP, and certainly our colleagues at the AP National Resource Center are able to connect anyone who is interested in finding out who their family-to-family program is in their state, who their Title V Children with Special Health Care Needs Director is. And I'd also like to shamelessly put a plug in for an AMCHIP learning module on the history of Title V Children and Youth Special Health Care Needs programs if anyone has been inspired to do a deeper dive into learning more about the origins and evolution of this program. And so thank you so much, Dr. Peterson and Dr. Hoffman, for sharing your experiences with us today, for sharing your tools and resources that are available to the public to learn more about this topic. We greatly appreciate your time and insights. And all of the resources discussed during this episode will be included as a PDF and archived on the National Resource Center website. If you would like to be connected with Dr. Peterson and Dr. Hoffman or have any technical assistance needs, the National Resource Center staff are available to facilitate introductions and provide those tools and resources. On the National Resource Center website below this recording, you will see a link to a short evaluation survey for this podcast series, and we would greatly appreciate your feedback. So this concludes the first episode of Gaining Ground, the primary care pediatrician's role in public health systems care for children and youth with special health care needs. Thank you so much for your participation.